Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. I'm Aly-Khan Lalani, joined by my co-host Chris Wallis, and we're just ahead of a special guest today, which we'll get to. Chris, we're back from ASCO, and we've already gotten into a few episodes. How are you feeling now looking out in the sun here in Toronto?
Oh, that's good. We had a late spring, I would say, a nice transition to a quick summer. And we're building on now our Alberta special, I guess. We went from Winston Chong. We had the Alberta connection starting in Calgary, and now we're migrating north to Edmonton.
Yeah, no, it's great. And I'm just going to introduce our speaker, but to those of you watching at home, this kind of builds upon our episodes where we've had imaging episodes with Dr. Fred Pouillot, which we'd invite you to return to, kind of the imaging in prostate cancer. And then we've had a little bit about dovetailing into radioligand therapy, but so much of our cancer care conversation happens after folks are diagnosed. I think a key component, and obviously something urologists and uro-oncologists are heavily into, is even getting to that diagnosis. And so really my pleasure to introduce Dr. Adam Kinnaird, who's a uro-oncologist and the Alberta Cancer Research Institute chair, the Frank and Carla Sajonki chair in prostate cancer research at my old alma mater in Edmonton at U of A. Adam, thanks so much for joining us.
Thank you very much for having me. It's a pleasure to be here.
So Chris, why don't you take us through the historical concept of truss and systematic biopsies as we kind of get into alternate or more novel ways of doing things?
Yeah, absolutely. I got to say, just before we jump there, it's a real pleasure having Adam on the podcast. We met each other back as fourth-year med students doing electives here in Toronto, and we followed sort of parallel paths since that time. I stuck around Toronto for residency. Adam went back to Alberta. We both managed to stumble our way through some graduate degrees and a little bit of fellowship and landed back in faculty jobs around the same time. So it's been really sort of awesome to watch Adam's career trajectory just take off. And he is, I have to say, one of the sort of thought leaders for us in Canada in terms of, prostate imaging and how we go about assessing patients with prostate cancer from an imaging perspective around diagnosis, understanding risk burden. And so I think this is going to be a great session at the front end of that whole trajectory, as you alluded to, before we get to prostate cancer diagnosis. And to set this sort of context, I think we need to go back about 35 years, maybe a little more, to an era whereby we didn't really have routine PSA screening. We weren't looking for prostate cancer, but we knew that prostate cancer was a problem. And so we started off with finger-guided biopsies, right? We're talking about a digital rectal examination. You feel a nodule, you stick a needle in it. And as soon as we started doing PSA testing and seeing that we were, diagnosing much earlier disease, we needed to have a better way to guide our biopsies than just blind finger biopsies. And so transrectal ultrasound became sort of the go-to workhorse in local prostate evaluation. But Adam, as you know, and we can speak to a truss biopsy, our truss-guided biopsy with just systematic evaluation of the prostate has numerous flaws and led to, interest in doing it better. And so maybe in that context, the first big leap was about, maybe 2015 or so, in the idea of a pre-biopsy MRI. And maybe you can help us sort of level set and understand the sort of role of pre-biopsy MRI and the precision and precise data that led us to that now guideline recommendation.
Yeah, for sure. So certainly when transrectal ultrasound became a thing, really what we were trying to, or what scientists then were trying to figure out, was how many cords could you stick in a prostate to find prostate cancer? So was it 6 biopsies? Then it was 10 biopsies, then it was 12 biopsies, then it was saturation biopsies. And really what that was getting at was trying to find small cancers that are treatable, that are clinically localized, that you can do a radical prostatectomy on or give radiation therapy to. And so that's where MRI really became a thing. And so, prostate MRI has been around for even longer than 20, 25 years, but it has been honed down to this new thing that is led by guidelines, the PIRAD scoring system that has been through several iterations. And what the prostate MRI really relies on is it relies on either diffusion-weighted imaging, which is the backbone, or T2-weighted imaging, plus some dynamic contrast enhancement, which I'm sure we'll talk about later, as this has been sort of a big thing in prostate MRI recently about whether you can do biparametric MRI or multiparametric MRI. But certainly over the last 10 years, with the sort of general uptake of prostate MRI prior to a biopsy, it has enabled us to find more prostate cancer that is clinically significant, take away prostate cancer that is clinically insignificant, and get a diagnosis more accurately.
Yeah, so I think you highlighted there exactly the three major benefits I quote to my patients when we're thinking about the role of pre-biopsy MRI, and that's, biopsy avoidance in some subset of patients with elevated PSAs, where we then figure out that based on the MRI, they probably don't need a biopsy because they harbor such low risk of clinically significant disease. And then, as you say, a better biopsy, which gets you to a higher diagnosis of clinically significant disease. And then probably mostly through that biopsy avoidance mechanism, lower diagnosis of that clinically insignificant disease. And I think, just a quick shout out for clinicians trying to take these ideas into practice. Adam has a very, very nice nomogram he developed while at UCLA. It's on the UCLA website. You can put in your patient's characteristics in the way that you'd be used to from like a PCPT risk calculator, and then add a few MRI details, and it can give you a pretty good assessment of the probability of clinically significant disease and help you in your conversations with your patients when deciding whether to jump from that MRI to a biopsy or just some more sort of conservative approaches. And so, Adam, maybe as we're trying to interpret that MRI, tell me your thoughts on how you assess, who needs a biopsy, who doesn't after an MRI. I think, there's what the clinical trials did, and then there's the rollout of what that looks like in practice. And so for a multiparametric MRI that's going to read out the way that Precision, for example, would have, how do you approach PIRADS 1, PIRADS 2, PIRADS 3, PIRADS 4, PIRADS 5 sort of patients?
Yeah, so I combine the PIRAD score with the PSA density. So another important aspect of prostate MRI that often gets overlooked is that it gives you the most accurate volume assessment of a prostate gland out of any imaging test. And certainly we know that PSA density, PSA isn't a great test, but PSA density is a pretty good test. And so when we have men who are PIRADS 1 or 2, we consider that negative. PIRADS 3, 4, or 5, that's considered positive. Typically, you quote a man about a 25% risk of clinically significant cancer with PIRADS 3, about a 60% chance with PIRADS 4, and about an 89-90% chance with PIRADS 5. But in those, so certainly in the 3, 4, and 5, you're going to be counseling biopsy. In the UK, with PIRADS 3, they still want to have a slightly elevated PSA density of 0.12 or more. And then what I do is that if you have a PSA density of 0.15 or more and a negative MRI, I still talk to the patient about potential biopsy and potentially using an adjunct imaging strategy like micro-ultrasound.
Can I ask, just even, this is great because, if we take a step back, what's your experience? And maybe you can speak to both of you, your centers where you're at, maybe you discussion with colleagues across the country or even around the world. What is the real wait time and access issue with getting an MRI? Because I think that's the first point you guys are talking about. I'm just curious as to what a urologist or uro-oncologist is feeling when they put in that order for the MRI. What is their expectation that they talk to patients about?
So I can tackle this first. So certainly when I did fellowship in the United States, it was not a big deal to be able to get a prostate MRI. It was something in the order of magnitude of days to weeks. But in Canada, at least in Alberta, it is approximately a 5 to 6 month wait list to get a prostate MRI. And when you think about it, we currently have over 1,000 patients referred to our clinic. We have a centralized clinic in Northern Alberta in Edmonton where we see all the patients in Northern Alberta. We have 1,000 patients waiting to see us for an elevated PSA, and they typically wait about a year to see us. And then you get another 6 month wait in terms of doing the MRI, and then another couple month wait in terms of doing the biopsy, and then a couple weeks to get the results. You are waiting a very long time in Alberta to be able to go from elevated PSA screening positive to getting a diagnosis of prostate cancer. So certainly that is one of the major limitations of MRI, is that there is the wait time.
Yeah. In Toronto, I would say that in general, things are not that different. I know certainly there's colleagues of mine around the GTA who have, 9 to 12 month waits. And for many younger men, this is like prohibitive, right? They're not willing to wait that long with the uncertainty of suspected prostate cancer. And so I definitely have patients, and I'm sure you do, Adam, who opt out of an imaging-based approach pre-biopsy when I would strongly recommend it. And I say it to my patients, if I could get an MRI before biopsy within 2 weeks, no one would get a biopsy without an MRI. But now you have to slightly consider the pretest probability questions and how it changes your management to say, is it worthwhile waiting or not? And you alluded to this, Adam. One of the issues is that we have, rather than the orthopedic surgeons, we use multiparametric MRI, which requires intravenous gadolinium, and as a result requires a radiologist on site for potential contrast reactions. So these are not MRIs that can happen at 2 a.m. like your knee or your hip MRIs do. And so, one potential way to increase the AMR throughput by 2 mechanisms is to move to a biparametric MRI approach. So by omitting the intravenous gadolinium, you A, make it a shorter scan, there's less time, but B, open up other time slots to prostate MRI. So Adam, you want to talk a little bit about like Prime and what we were thinking in the biparametric setting? I know that in some places in Ontario, I'll just say like Ottawa, they've already routinely adopted biparametric as their go-to imaging modality for first-line prostate evaluation.
Yeah, so Prime is a great study led out of the UK that compared biparametric MRI in men and multiparametric MRI. And basically, the key thing with this is that in the PIRAD scoring system, the dynamic contrast enhancement component doesn't really take you from being negative to being positive. It only takes you from being slightly positive to more positive. And so really, you could just say that you're positive and you should go on to a biopsy. And I think that this has the potential to really open up the accessibility of MRI for patients in Canada for the reasons that Chris said. Certainly, if we could scan people throughout the night, I know that it is not an issue with actual magnets and the number of magnets that we have available to us in Edmonton. It's actually with staffing and the number of people that we have staffing this throughout the day, having to have a radiologist there.
And so, if we're looking at these, we're looking at ways to optimize MR, but maybe walk us through micro-ultrasound as an alternative. I think, you can maybe help us give us context. Is the goal of MR goal of micro-ultrasound to complement MR, to supplant MR, to do a bit of both? How do you see it sort of, before we dive into it, what's the context of why we're even interested in looking at micro-ultrasound?
Yeah, so this is a really exciting topic for me personally, because I have several studies in this space that are currently ongoing and that have been published. And I'd love to talk about those today. So micro-ultrasound is a novel imaging test. It's been around for over 20 years, but it was used to image like mice brains in utero, so like 100 megahertz. So now it has been honed down to not be quite as zoomed in, but using a 29 megahertz probe. Standard or conventional ultrasound probes are between 7 and 9 megahertz. So you end up getting about a 300% increased resolution with micro-ultrasound that is used. And there's only one available to purchase right now called the Exact View by Exact Imaging, which is a Canadian company. It's based in Toronto. And so this has been studied in a couple different scenarios: biopsy naive, prior negative biopsy, active surveillance. And the big study that we have right now that just came out in March is the Optimum trial. And so what we showed in the Optimum trial is we didn't aim to show whether it was better than MRI. We aimed to show that it was non-inferior. And so this was a multi-center international randomized control trial that was done at 20 different centers in 8 countries. And it was an interesting trial because it wasn't a 2-arm trial, it was a 3-arm trial. And in this trial, there was one arm that was micro-ultrasound only, so no MRI, no way that you could be confounded by an unblinded MRI to the user. There was an MRI ultrasound fusion group, so that's the standard type of MRI biopsy that is done. And then there was a third group that was received MRI and micro-ultrasound biopsy. But the user of the biopsy device was blinded to the results of the MRI before, while they were taking their micro-ultrasound biopsy, and then were unblinded halfway through the biopsy procedure. And at the end of the day, what this trial showed is it showed that when we use micro-ultrasound, we diagnosed clinically significant cancer defined as grade group 2 or higher in 46% of patients when we used micro-ultrasound versus 42% of patients when we used MRI. And this trial was actually closed early at the 50% recruitment for success. And so possibly one of my greatest regrets is that it was closed early, because with those numbers, if we had continued to 1,200 men that it was powered for, it is possible that we might have had a situation like the precision trial where you aim to show non-inferiority, but you actually show superiority. But for right now, the best that we can say is that in the biopsy naive patient, we have level 1 evidence saying that when you do the biopsy, you can use micro-ultrasound or you can use MRI. But I will say, and I know this is a long-winded answer, and this segues into a clinical trial of mine that's currently ongoing and is going to be done right now. 17 centers across the world in North America, South America, Europe, and Asia have signed on to this. And this is called the music screen trial. And where this is different than Optimum is that Optimum was only looking at the biopsy space, whereas it was every man got a biopsy. So even if their imaging was negative, which is not real world. In real world, if the MRI is negative, most of the time you're not going to be doing a biopsy. So music screen moves one step earlier, where men who are biopsy naive, imaging naive, they get randomized 1-to-1 to receive an MRI or a micro-ultrasound. And if the imaging is negative, you avoid biopsy. Whereas if the imaging is positive, you go on to biopsy. So I think that this will really help out with the applicability and generalizability of micro-ultrasound into practice if a positive trial.
Adam, I love it. This is like literally worldwide practice-changing evidence that's being led out of Edmonton, which I think is great. I have 3 practical questions around Optimum results and then how we roll it into the music screen. So number 1 is every patient in your Optimum trial got a systematic biopsy. To what degree does that just, wash out any imaging benefit effects here? Like, if there's minute differences based on imaging, if everyone's just going to throw a systematic biopsy in there, how do we get around that when we're looking at a non-inferiority kind of design?
Yeah, so that's a really good question. And so we studied this looking at, so everybody did get a targeted plus systematic biopsy. And the reason for that is that negative imaging also needed to get a biopsy as well. When we looked at targeted only cores, and we took 3 targeted cores per lesion, we found that there was no difference in terms of the detection of clinically significant cancer between groups. So if you just did a targeted biopsy, it was also similar. Now, I'm actually a believer in systematic biopsies. So the reason why I'm a believer in systematic biopsies is because I also do focal therapy. And so I think that the main issue with focal therapy is not that boiling something, freezing something, electrocuting something, using a laser on something doesn't kill tissue. That definitely kills tissue. The issue is that we don't know exactly where the tumor margins are. And so this is a huge amount of my research, is trying to figure out better tumor estimation of not only where's the margin, but bilaterality and multifocality using PSMA PET. I have a randomized control trial doing this. And so this is where I think that systematic biopsies give you that extra degree of certainty that there is no cancer elsewhere in the prostate and only where you are actually ablating.
I love it. It's a little tangent, but I totally agree. If you only want to make a diagnosis, if you only care cancer, yes, no, target's usually all you need. But if you actually want to understand the disease burden and tailor therapy appropriately to the patient, you often need to look elsewhere in the gland. So I completely agree. Now, the second question I have for people who are interested in micro-ultrasound, looking to roll this out. We know about PIRADs for interpreting MRI. How are we interpreting micro-ultrasounds, and how do we get reproducibility and ability to communicate between clinicians about what they're seeing? Because ultrasound images, you can save images clearly, but it's not quite the same as having an MR in your PAC system to just scroll through at your will later on.
Yeah, so now the nice thing is that these images do get saved to PACS. But with micro-ultrasound, the analogous scoring system is called the Primus scoring system. And the Primus scoring system is also a Likert score of 1 to 5, with 1 and 2 being considered negative and 3, 4, and 5 being considered positive. Now, the Primus scoring system is in its version 1.0. it has not been revised yet. And that is something that we definitely have to do. So for example, one of the patterns that makes it a Primus 4 is called starry sky appearance. And almost every time I see this starry sky appearance, it is inflammation. This is actually what inflammation looks like on micro-ultrasound. So I think that we have to do an iteration on this. And this is also where, at the same time, in parallel, using artificial intelligence is going to be, and computer vision is going to be so important. So all of these patients who are in our trials, whether it was Optimum, Music Screen, Music Active Surveillance, whatever it is, all these images are being saved in a central imaging repository and being stored and labeled for machine learning, which I think will really help us by overlaying a heat map to say this area looks super suspicious, this area doesn't, biopsy this area, not this area.
I love it. And so that gets to a question that is very practical. And AK, I know I'm dominating here, but we've got such a good mind. I can't help but pick at it. So when I use micro-ultrasound, and we can talk a little bit about indications and which patients you would pick, but when I order it, the dilemma I have when I'm using it in a biopsy-naive patient who doesn't have an MRI to inform me is, do I prophylax or do I not prophylax? Because as I see it, there's an option where you do a diagnostic micro-ultrasound. If you see no lesions, the patient doesn't need a biopsy. If you see lesions, they need a biopsy. So if you go diagnostic first, and then if they need a biopsy, you schedule a second one with prophylaxis and go ahead. Or you prophylax everyone before their micro-ultrasound, and the patients who have a negative ultrasound don't get a biopsy, got unnecessary antibiotic exposure potentially. And now we could talk about TP biopsy and maybe completely omitting antibiotic prophylaxis, at least where we are. Most patients, even for TP, are still getting some prophylaxis. That's the practice in our region. But I wonder your thoughts on like that logistic outflow. How do you do it in terms of antibiotic stewardship versus burden on patients and burden on the system?
So I feel like you sort of answered your own question, but so transperineal biopsy would be the way to go there with zero antibiotics. And that has been shown to be safe and effective with a 0% rate of infection. Now I do both transperineal and transrectal. And so in the Music Screen study, patients are getting prepped for biopsy in the event that they need a biopsy. But like you say, if the imaging is negative, then they don't get a biopsy. So then they took a dose of antibiotics for nothing. We're tracking adverse events. We'll see if it is something, but it sort of is a single dose of antibiotics. Hopefully it's water under the bridge.
This is great, Adam. And just as we turn the corner, we could talk on and on. I had maybe two last questions, and feel free both to chime in. I guess one thing I'm just curious, again, lay med-onc, but is there such a thing as discordant findings between micro-ultrasound and MRI? So micro-ultrasound positive, MRI negative, or vice versa? Is that a thing, and how can we mitigate that? Then I'll have one more after.
Yeah, that's a very good question. And so in the Optimum trial, we biopsied about 600 men. And we found that of this, 7 men were found to have clinically significant cancer that were MRI positive, micro-ultrasound negative, and 7 men were found to have clinically significant cancer that were micro-ultrasound positive, MRI negative. So it was a similar amount. It has not yet been studied what like the radiogenomic signature is that makes something micro-ultrasound positive versus micro-ultrasound negative, or MRI positive and micro-ultrasound negative. But really what you're visualizing with micro-ultrasound is you're visualizing the ductal architecture. And when prostate cancer forms, it fills the ducts. And so there's certain things like maybe intraductal carcinoma that might be better detected with micro-ultrasound because of the filling of the ducts.
That's great. No, that's helpful. And I guess one of my last ones would be, so let's assume I'm convinced your current study and the music, I love that, the ongoing music studies. Let's assume anyone on active surveillance, anyone who's not had a biopsy, everyone should be getting or considered for this. What's or is there much new investment needed from healthcare systems or hospitals to get the equipment needed? And then it strikes me that the person doing the ultrasound needs to be pretty talented, technically proficient, know what they're doing. So is this already a skill set people have? I presume there's some upskilling. So maybe technological investment or resource, and then also the human resource to upskill. Where would that be if we just adopted this now or in the future?
Yeah, so I'll tackle the actual infrastructure first. So one of the major limitations with MRI is that you need to have huge infrastructure for this. like buildings that are created that have special floors that can handle a certain weight. With micro-ultrasound, it is different. Micro-ultrasound could theoretically be rolled out anywhere where you have electricity. It's a point-of-care imaging modality. Now, the issue with training is certainly similar to MRI, where the more you do, probably the better you get. There are training programs offered by the company where you go from a beginner user to novice user to an advanced user to an expert user. And that's based over feedback from the company based on approximately, I think it's 70 to 90 biopsies that you do, and you you get direct feedback from the company on that. It has been studied that there is a learning curve and that doing this course actually improves the amount of clinically significant prostate cancer you find. Now, I will say, as someone who is a believer in micro-ultrasound, but I am also a huge believer in MRI, that the nice thing with MRI is that you put the diagnostic burden on the radiologist as well, because the radiologist has to look at it, and then you're just sort of pointing and aiming, which makes it very easy and very fun. But with micro-ultrasound, not only are you pointing and aiming, but you are also having to interpret the images as well in real time. And you're doing this while a man has a transrectal probe in. And so you want to be as quick as possible. And so I've done over 1,000 micro-ultrasound guided biopsies. And certainly the results were even surprising to me that it was so good. Because when you're doing it, you sort of are wondering, is what I am seeing real? But it turns out that yes, what you are seeing is real in a randomized control trial.
Awesome. Congratulations on this work and ongoing work. Chris, I'll give you a last question if you have. Otherwise, we can take it home.
Yeah, I think you alluded to this a little bit, Adam. Maybe if you forecast forward, looking 3-5 years, clearly there's an interest growing in pre-biopsy PSMA PET. How do we integrate all of the imaging options available to us to most optimally inform our care? Like, everybody doesn't need everything every time. So how do we make rational decisions about what to use when?
Yeah, that's a great question, Chris. So I would say this, and I'm going to base this on the fact that a guy named Jeffrey Son out of Stanford published that in 2022 in the US, probably the most resource nation in the world, only about 1/3 of men were getting pre-biopsy MRI, and that would drop down to about 1/4 of men if they lived in rural United States. So even in a heavily resourced nation, you are still only getting 1/4 to 1/3 of men who are getting following the guidelines for biopsy. So how do we do this going forward? I think if you incorporate micro-ultrasound into the diagnostic pathway, the one thing that you are not assessing anymore is you're not assessing the lymph nodes. And so this is where I see a combination of micro-ultrasound and PSMA PET, where you do the micro-ultrasound to get the local tissue diagnosis and the T staging of the prostate, and then you use PSMA PET to get the N staging and the M staging of the man. I wouldn't use, in Australia, they have amazing access to PSMA PET, but in Canada right now, to put every man on a scanner for PSMA PET, I think that would break the system for what we currently have and what we have probably for the next 10 to 20 years. Whereas micro-ultrasound is going to be plug and play, and the real issue is just going to be training the right experts on how to use it. And then once you have accumulated that critical mass, then it shouldn't be an issue.
Awesome. I mean, I'd love to get trained now after this episode, but honestly, it's been interesting, and I'm sure our urology and uro-oncology listeners and viewers are super keen. Hey, as a simple med-onc, I learned a lot today. So Adam, thank you so much for joining us. And again, congratulations for all the work you're doing and have already done in this space. To our listeners and viewers, don't forget to rate, review, subscribe. Hopefully you're enjoying your summers thus far. And on behalf of my co-host, Chris Wallis, I'm Aly-Khan Lalani. We'll see you next time.